Thank you everyone for joining us. I'm going to give everyone a few seconds to get registered and into the Zoom channel. I know there's always a little bit of a delay between when we open those virtual doors and when everyone gets settled. When I see the numbers start slowing down, we'll get underway. In the meantime, remind you all that I'm Dr. Samantha Hill. I'm president of the Ontario Medical Association. I'm a cardiac surgeon in downtown Toronto. And the Ontario Medical Association is pleased to be hosting these media briefings and helping you to provide the best science and the best evidence in your reports. Looks to me like we seem to have leveled out. So on that, I thank you again for joining us on this latest media briefing on important healthcare issues in the news today. I am Samantha Hill, again, president of the Ontario Medical Association. We represent more than 43,000 doctors and medical students across the province. And this week, we're here to answer some of the questions being asked about COVID. Questions like, what are these virus variants? Questions like, will the existing vaccines work against these new variants? And questions like, why is there still so much misinformation about COVID, particularly on social media? Today, we released some disturbing new information from the ASI market research film. They found a large number of Ontarians, 100,000 or more, were actively engaged in social media conversations about COVID hoaxes, lies, and misinformation. And while about a quarter of these people were trying to refute the misinformation, 3/4 or a little more were discussing whether the COVID-19 pandemic is a hoax and whether or not they should get the vaccine. It's findings like this that reinforce the importance of using science, research, and evidence to combat misinformation and make decisions about vaccines and pandemic restrictions. It's findings like this that reinforce the importance of listening to experts and getting your information from public health units and family doctors. I'm joined today by 4 esteemed physician colleagues who are experts in these various efforts. Dr. Jim Wright is the Chief of Economics, Policy, and Research Department here at the OMA. He's a pediatric orthopedic surgeon and was previously a professor of orthopedic surgery at Oxford University, Surgeon-in-Chief and Vice President at Sick Kids Hospital. Dr. Gerald Evans is the Chair of the Division of Infectious Diseases and a professor at Queen's University. He's a physician in internal medicine and infectious diseases at Kingston Health Sciences Center. Dr. Jennifer Kwan, a family physician in Burlington and co-founder of the advocacy groups Masks for Canada and Docs for LTC Justice. She's known for her daily Twitter dashboard updating COVID cases and deaths and vaccination rates, a dashboard many doctors consider to be daily required reading. And Dr. Fahad Razak is an internist and an epidemiologist at St. Michael's Hospital in Toronto. He's co-founder of the General Medicine Inpatient Initiative, or Gemini, the largest hospital-based big data network in Canada. Both Drs. Razak and Evans are members of the Ontario COVID-19 Science Advisory Table, a group of scientific experts and health system leaders who evaluate and report on emerging evidence related to the COVID-19 pandemic and to inform Ontario's response. We're very lucky to have all 4 of these people here today. Dr. Wright, I'll turn it over to you for a few opening remarks.
Thank you, Samantha. My name is Jim Wright. The Physicians of Ontario, like other healthcare workers, have been fully engaged in treating patients who've been afflicted with COVID. But the role of the OMA is to bring the voices of physicians in both responding to the pandemic and planning for the next phase, the light at the end of the tunnel, which is the C-19 vaccine. We've all come to rely on our public health colleagues who've taken a leadership role in the province in using their expertise. But I would say perhaps behind the scene, there are other disciplines who've had a key role. And we're bringing some of those physicians to you today to share their expertise, which has been so important and will continue to be so important as we both deal with the pandemic and plan for vaccination. So I'll turn it back to you, Samantha.
Thank you. Thank you so much, Jim. Thank you so much, Jim. So The first person to speak with us will be Dr. Evans, and he'll be talking about the virus variants. What are they, and will existing vaccines work against them? Dr. Evans, would you be so kind as to talk to us about how the COVID virus is mutating and what that means?
Thank you very much. I'm happy to. I'm going to take about 3 minutes to try and give you guys all the basic background on virus variants. So the real questions are, what are they? How did they happen? And you know, I think the big question, which is, what will the existing vaccines protect against these particular variants? So just a very quick background. Everyone should know that viruses mutate, and they do that when they replicate. It's not their fault. It's a random occurrence, and this has always happened with viruses, and it explains their viral evolution. Got to go back to the first slide. I've shown here basically the groups of viruses where SARS-CoV-2 lies. They're negative sense RNA viruses, and they tend to replicate at a sort of modest rate depending on their genomic size. So the real problem that we're facing in the world is there's a lot of viral replication going on because there's hundreds of millions of cases, and each of those cases is going to generate mutations. Next slide. This just shows the difference on the left-hand side between the wild-type SARS coronavirus, what's called now the Wuhan strain, and the B.1.1.7 variant, which arose in the UK on the right-hand side. And those little marker bars, basically to the right-hand side in that red zone, show you that most of the mutations that are occurring are in the spike protein. And that's incredibly important because the spike protein is where we aim our vaccines to have activity against by developing antibodies against it. Next slide. So there's a number of variants that we're concerned about at the moment. The first one that arose was the one in the UK called B.1.1.7. And since then, we've had other variants, including some arising in South Africa and Brazil, and even in the United States, all of whom have different numbers associated with them. The table at the bottom shows how many of these mutations are occurring in these particular variants. And what's really interesting is that they're popping up all over the world, not surprising. Viruses mutate, but some of the mutations that are occurring tend to have a recurrent theme. And again, most of them are in the spike protein, and they have an effect on the transmissibility of the virus, as well as the potential for vaccine escape. Next slide. And why are we really concerned? Because there's worldwide spread, and it's not uncommon. They've arisen either de novo in some parts of the world, or the international travel, which has continued over the last few months through the fall, has allowed for them to spread elsewhere. What you see is a map indicating sort of a spread of these variants. The orange and red ones are the more recent ones. And then the small graph at the bottom shows you that now, over time, starting way back in January 2020 till now, these red and orange variants, the ones that we're worried about, have started to climb up as part of the general overall frequency of virus. Next slide. This is just a quick graph to show you what has happened with B.1.1.7. It has spread around the world. Not only has it traveled elsewhere, but we've actually now got evidence of local transmission, particularly in North America and in Europe. Next slide. So why are we concerned about them otherwise? Well, we're concerned because there are consequences to emerging mutations and variants. There's a possibility of increased transmissibility. There's a problem with potential for increased virulence, that is, produces a more severe form of COVID-19. And of course, our concern about protection from vaccines, which we currently have developed or are developing, or the immunity you might get from a natural infection. Next slide. So this is just to show you that transmissibility is a real thing. It's a funny looking graph, but basically the orangey areas, which you can see up top, indicate that the B.1.1.7 variant has a higher reproductive number. And in this case, if you look at the left-hand side of that graph, it's about 2, as compared with the wild type virus, which is in the green and purple and pink colors, which is closer down to 1 or 1.5. So they are more transmissible, and certainly B.1.1.7 is characteristic of that. Next slide. The one interesting thing so far, at least, is that these variants are protected for with our current vaccine. On the left-hand slide, you see a comparison between the wild-type virus on the vertical axis and the mutant virus on the horizontal axis. And basically, there's a very good correlation of almost 1 in that the antibodies produced by patient sera which have been vaccinated is equally effective. On the right-hand side, you see a comparison between the Wuhan wild-type virus and B.1.1.7, showing that, generally speaking, the amount of antibody required to neutralize the virus remains equal. Next slide. Why is this important? Because there's really some good modeling data, and this is from an American study, but it's probably applicable to Ontario, that even if you maintain the reproductive number currently we have, which is about 0.9, the impact of the B117 variant you can see in the light purple areas is quite substantial without vaccine on the left-hand side and even with vaccine on the right-hand side. So part of the answer here is that these variants we have to control, and this does show that vaccine will help to control those rise in numbers over time. Next slide. The other thing that we need to do is we need to look for these variants, and there's a kind of problem here in that some parts of the world, the United Kingdom and Denmark are nice examples, have led the pack when it comes to sequencing viruses that are that they have, so that we can find these variants. Unfortunately, Canada is marked with the red arrows somewhere in the middle, and really could be doing more, and we would certainly hope to be doing more for looking for these. Next slide. So basically, in summary, variants have arisen worldwide, and they are changing the dynamics of the pandemic. We know there's increased transmissibility with some of them. There may be some virulent signal, but that's still unclear. And reduced protection from vaccine-induced immunity or prior infection is a clear and present danger if some of these mutations end up conferring that. So our current strategies to combat variants should be to reduce the overall number of cases. If you have less viral replication, you're going to have less mutations and variants arising. We need to speed up vaccination of the global population because that's a strategy to reduce these variants moving around. And we need to track variants better to detect their emergence and then understand the implications of them arising. So I'm going to stop at that point and give it back to Dr. Hill.
Thank you, Dr. Evans. I suspect most of the reporters currently have whiplash, so I'm just going to double back on that a little bit. So you were mentioning about the virus variants, and if you look at that last slide that you had, which is a perfect slide, what I see that you've said is that we're worried about the variants because they're definitely more contagious. They may or may not be more dangerous or more virulent. And we worry about the immunity that's provided by vaccines and whether or not they will be equally effective or sufficiently effective on the new variants. Is that safe to or fair to say?
Sorry, absolutely perfect. I must have said it correctly. You picked it up perfectly.
Excellent. And what I see on the bottom part of that slide is that the way that we combat the new variants isn't actually necessarily about targeting those variants, but it's a lot of the things that we already know that we're trying to do. So reduce the number of cases so there are less opportunities for the virus to multiply and replicate and get new mutations. And part of doing that would be vaccinating as many people as fast as possible. And then that last part is about improved tracking. And so that's about identifying people or variants of the virus, people who have them, so that we can figure out exactly what the implications are, because at present, we still really just don't know completely. Is that right?
You're absolutely right. That's perfect.
Perfect. All right. Thank you. And I'll remind reporters that if there are any questions about the science or anything else that Dr. Evans said, you are free to put it into the Q&A and we can come back to it and make sure that that's clear for everyone. There was a lot of excellent information in there. So moving on to the next topic, which will be directed to Dr. Kwan, we're going to talk about how we build vaccine confidence. We've seen how important getting vaccinated is. We know that it's important for our current wild strain and for the variants that are coming at us. So what are patients asking us about the COVID vaccine? Are they the same questions that we see on social media, or are they different? And how can family doctors be more involved in vaccines? After all, family doctors do have a cherished and special relationship with their patients. And finally, last but not least, are vaccine selfies turning into vaccine jealousy? And I'm looking forward to hearing the answer from that one, Dr. Kwan, because I know when I posted my first dose selfie, a couple of people thought that it was boastful, which certainly wasn't the intent. So Dr. Kwan, a family physician, an active user of social media, and a leader amongst your peers, would you tackle that?
Yeah, thanks so much, Dr. Hill. So as a family physician, we are positioned in a unique place that we can advocate for vaccine hesitancy amongst our patient population. So doctors are trusted experts, and we develop relationships with patients and their family over years, and we understand their individual concerns. So not just about the COVID vaccine, but we also do lots of other vaccinations, childhood immunizations, tetanus shots, pneumonia shots, shingles shots, hepatitis, etc. So we also do vaccinate millions of people per year with the flu shots. And we understand not just actual vaccination, but also the whole process of management, ordering supplies, syringes, bandages, swabs, calling patients to come in for it, booking them in, the vaccination, and then monitoring and documentation. So there is a full process that we in primary care are excited to be involved in. And we also do hear feedback from patients of all ages and backgrounds. The main questions I'm getting are, when exactly are we going to get the vaccine? And unfortunately, I do not have the answer to this for most of my patients who are not in the tier 1 priority list with frontline healthcare workers or high risk people in long-term cares. And unfortunately, for some people in those groups, we still don't know either. Another question I am asked is, which vaccine is right for me? And I would say whichever one is available to you at this point in time. We have the Pfizer and the Moderna, both have relatively excellent efficacy. And then we also have questions for our individual patients who have unique medical backgrounds. They're on special medications, some may be on immunosuppressants or undergoing cancer treatments, or maybe pregnant or planning on pregnancy. And this is good because for these types of patients, we have their whole file. We know about any allergies or concerns, and when needed, I can liaise with their specialist so that we can get their specialist opinion whether the vaccine would be appropriate for special cases. In general, patients are actually very eager to get the vaccine, and I do hear a lot of people say, oh, I don't want the flu shot this year, but I would be very interested in getting the COVID vaccine. So we do try and encourage patients to ask questions, and so that they can understand the benefits of the COVID vaccine. Sometimes I do mention that I have gotten it because I'm a frontline healthcare worker, and they will ask me for my personal experience and any side effects, which were minimal. So that brings me to the last point, which is addressing vaccine hesitancy on social media. So it is very important to combat the misinformation that is spreading about the vaccine. And generally, I try to do it in a more positive and encouraging manner. It's very important that there is a difference between vaccine hesitancy and anti-vaxxer. A lot of people have genuinely good questions, and we can direct them to resources such as the Center for Effective Practice or the SOGC or other medical organizations that have published great information based on facts and research on the COVID vaccine. With regards to the vaccine selfies, I see that as a positive way of promoting the vaccine so that people can see, oh, these are real doctors and people getting the vaccine, and they're doing pretty well. They're honestly reporting their side effects or any concerns they have. But with the problem with the lack of vaccines for some people who do deserve them, such as high-risk people or other frontline healthcare workers, it has been a bit of a challenge because now we are fighting two battles, one for vaccine hesitancy and one for inadequate supply. So it's not an easy answer. Personally, I posted the vaccine selfie of the first one, but not the second one. But we just really want to encourage advocacy on supply of vaccines so that all the high-risk people can get their shot as soon as possible.
Thank you so much, Dr. Kwan. That was a great summary. So many challenges as we go forward and so many opportunities to have impact. The next question, which will go over to Dr. Razak. Why is the science, the research, and the evidence so important when it comes to combating COVID misinformation? Dr. Razak, can you please talk about some of the work that you're doing with big data, using the data that's generated as part of routine medical care to improve hospital processes and patient outcomes?
Thanks, Samantha. It's a great pleasure to be on this panel. So I want to talk about, we've heard from some of our panelists about some of the challenges that we're facing, but Ontario's doctors are leading some of the responses. And this is really a great example of an initiative which has grown over the last 5 years and really become especially valuable during the time of COVID. So what we are really focused on is generating detailed data on hospitalized patients. And historically, this has been a major gap in Canada and something that we've accelerated to try and address as we enter the COVID pandemic. Next slide. I'm just going to briefly make a couple of points about the barrier. We've written more about this in the Hill Times last year, and it's really a description of where Canada's outdated data infrastructure can lead to challenges. And especially there's an opportunity to harness electronic data, extremely rich data that's generated as part of routine clinical care. So you don't have to invest in a study to generate more data. This is the blood test that your doctor orders, or an X-ray, or the medication that they prescribe. That data, when you aggregate it over hundreds of thousands or millions of Canadians, is the very kind of big data which is perfect for using advanced methods like artificial intelligence. Historically, a lot of this data has unfortunately not been largely accessible for health system planning, to improve the care of an individual patient, or for research. And that's really where myself and a large network of physicians across Ontario have really focused on trying to address that problem. Next slide, please. So the platform that we've built is called Gemini. It's by far Canada's largest hospital data platform. It holds data on hundreds of thousands of Canadians, very detailed data, every single lab test that's ordered, medications, an X-ray or a CT scan, it's all within the Gemini repository. It now includes 30 of the largest hospitals in Ontario, covering roughly 70% of the province. And we've now partnered very closely with Canada's leading institutions for artificial intelligence. As many of you know, Canada has been a pioneer in artificial intelligence. And so groups like the Vector Institute are now using this database to do advanced analytics. So I want to tell you a couple of just high-level examples of how we're using that data to inform the pandemic response. The first is around COVID itself. It still remains a mysterious illness, and the best available test we have in Ontario for COVID may miss as many as 1 in 4 cases of COVID. The swab will come back negative. You can use advanced prediction algorithms like artificial intelligence to try and determine if that swab is going to be positive, whether that patient eventually will be someone who will consider to be a case of COVID. That's important because the precautions we have to take in hospital around personal protective equipment, the kind of barriers we put in place, they're considerable, and it's a constrained resource. So we're using big data to inform the use of this limited resource, the personal protective equipment. Another great example is knowing what happens to patients with COVID when they're admitted. As you know, Ontario has run through a very difficult time now with ward capacity and ICU capacity. Can you use big data upfront to help predict who's going to deteriorate, who will need that ventilator? A third example I want to give, and we've described this a bit more in this article that I've referenced in the Globe and Mail, is how you can look to hospital organization to help respond to the COVID pandemic. So let me just give you a simple example. Currently in Ontario's hospitals, there's about a 40% decline in discharges from hospital that occurs on weekends. A lot of that decline happens because of inability to send a patient to a nursing home or to a rehabilitation facility. Data can help you determine what kind of patients could be shifted safely in a 24/7 system, acknowledging that people get sick on weekends, people get sick overnight. And because we have such a constrained capacity in Ontario, this kind of data can be very informative to help for health system planning. As I was sharing some of the data with our OMA colleagues, they said that these slides about the impact of COVID on what happened in hospital could be really interesting to present. So this is just a very brief summary of what we saw as COVID started. This is data from 7 very large hospitals in the Toronto area. The y-axis here is the number of patients admitted to medical wards. So as you can see, November, December, January was hovering at around 2,000 patients admitted at these 7 hospitals. And then over a 4-week period at the start of the pandemic, there was a nearly 50% decline in the number of patients who were hospitalized. That's remarkable because if you think about hospitalizations, many of them occur for conditions which are emergencies, and you wouldn't anticipate that they should drop even if there's a COVID pandemic. And I'll give you some examples on the next slide. So conditions like stroke, heart attacks, exacerbations of underlying conditions like heart failure or obstructive airway disease, which is called COPD. Each of these conditions, the number of people presenting to hospital with these conditions dropped by nearly 50% in just a 4-week period at the start of the pandemic. So you require the kind of big data that I mentioned to see these trends. And these trends are really important to identify because they highlight areas where we may need to be more proactive in reaching out to the people of Ontario to improve their health. I'll just give you one example from Italy. They found a similar drop of presentations to hospital with heart attacks during the first wave of their pandemic. That was a signal to them that they need to look out into the community to see what's happened. And lo and behold, they found that there was a dramatic increase in the number of sudden deaths from heart attack in the community. So the message being people were afraid to come to hospital. They were afraid of COVID. They started to have symptoms of things like a heart attack. They never came in and they ended up dying outside of hospital. And this is just another example where big data can reveal these important findings that are very actionable.
Excellent. Thank you so much. Obviously, a lot to be learned still, and a lot of capacity to use the transformative ability of AI and big data to better allow us to care for our patients more effectively, more efficiently, and with greater safety. Before we turn over to the media, Dr. Wright, do you have any last words before we move on?
I just think it's a wonderful illustration that many of us, I have a family doctor who looks after me, and there are doctors who work in hospitals. So we're very familiar with the doctors and nurses who look after patients. But individuals on this panel show the ability to use their expertise to treat the entire province, and in some cases, the entire world. And I think I just have to say I'm impressed, and I'm delighted that we're able to bring this level of expertise to people and have their question to the media and have their questions answered. So thank you, Samantha.
Thank you. I couldn't agree more. I think we are very privileged to have such esteemed people and such bright minds working on our behalf. So with that, thank you, Doctors Wright, Evans, Kwan, and Razak. We're now going to open up our Q&A session. I know there's already one question in the Q&A and we'll address it, but I'll encourage people to add more. This is your chance to ask some of the brightest minds questions on an almost one-to-one. Morgan Cates from Crestview Strategy is on the line, and she'll be taking your questions in the Q&A chat and getting them out to the right person. If there are too many questions and we don't get to them all due to time, the media team will follow up with the individual reporters to make sure that you get answers to your questions. You can also email media@oma.org with questions, additional requests for interview, or any follow-up that you need. Finally, we will welcome any suggestions that you have for future topics for OMA media briefings, and we will have a recording of this session available later this afternoon if you need to come back and review it. Over to you, Morgan.
Great, thank you so much, Dr. Hill, and thank you to the panelists. We do have a number of questions coming in over email as well, but I will start with this one in the Q&A from Ray Chan. He is asking, there are 2 vaccines today. Which is better? It seems people are very worried with the Pfizer vaccine. I think it'd be great to get Dr. Evans to answer that question. Then maybe we can ask Dr. Kwan for her perspective on how she talks to her patients in the family practice. Dr. Evans?
So thanks very much. So if you look at the 2 current mRNA vaccines, Pfizer and the Moderna one, really their efficacy is virtually identical. If you look at side effect profiles, and certainly reporting on about 2 million doses of Pfizer and about 4 million doses of Moderna that the Americans have released, the side effect profile is also pretty much the same. There are very rare cases of more severe reactions, and even those ones are really not the more severe form of anaphylaxis. Almost all of them occur within 15 minutes, which is why we kind of observe people after they've had the vaccine. But there have been no deaths from vaccine and no severe hospitalizations required from them. So the problem with that question is they're really essentially the same. I think if either one is offered to you, you should take them. There's essentially no difference.
Great, thank you, Dr. Kwan. Do you want to add your perspective on that from a family physician practice perspective?
Yes, I would echo what Dr. Evans said. Both the Pfizer and Moderna vaccines are very effective. They're both mRNA vaccines requiring 2 doses, and I would recommend just taking whichever one is offered first.
That's great, thank you. Thank you, and that question was from Ray Chan at Sing Tao. Thank you. I have Mark Bennett from Your TV who is asking, what role do you hope that Ontarians get that vaccine? That Ontarians that get the vaccine, can play in the fight against misinformation. I'll just go back to Dr. Kwan, since we all know you're a social media maven, where you talked a little bit about the vaccine selfies. What else can Ontarians do? And then I'll have Dr. Hill build on your comment.
Well, I think anyone who gets the vaccine, you can also report, you can post a selfie, you can talk to your friends and family about your experience. Sometimes people just want to hear exactly what happened, how you went to the hospital, was there a lot of lines, how did the consent process go, how did the actual injection feel? And I think talking about that makes people more comfortable. So even if you are not a physician, it's good to be able to speak to your personal social networks and talk about the experience. And that's why talking about it is important, because oftentimes we only hear about some rare, severe issues, but the vast majority of people do just fine. So talking about that will also help fight vaccine hesitancy.
Thank you, Dr. Kwan. Dr. Hill?
Thanks so much. So I just wanted to applaud Mark for asking that question. At the end of the day, we have policymakers and we have scientists doing the higher level work, but whether we win or lose the fight against the pandemic depends on the choices that the individual Ontarians are making every single day. It's why we did so well during the first wave, is because people heard and they listened and they stayed home and they stayed away from each other. And I'm not saying it was easy for anyone or that it came without unintended consequences. We know that there were, but it's the actions every single day and the decisions every single day that Ontarians are making that makes a difference. And that will be exactly the same situation with the vaccine. Whether or not you get your vaccine is going to make a difference. Whether or not you talk to people about having gotten your vaccine, you tell them about how easy it was, or if you had some side effects, what they were and how you're still happy that you got the vaccine, because whatever that side effect was, swelling arm, itchy, feeling like crap for a day or two, it's still better than having COVID and having potentially infected your family or having wound up in the hospital in the ICU. So again, just a congratulations to Mark for raising that question and realizing that the power to get past this pandemic really does lie with the Ontarians.
Thank you, Dr. Hill. We have a great question for Dr. Wright from Holly Mackenzie Sutter at the Canadian Press. The question is, specifically, what could Ontario and Canada do to improve screening for the new variants?
So I want to also weigh in on the previous question. In getting any treatment, you have to get advice from someone you trust. And in many cases, that might be your primary care provider, your family physician, but the other people you really trust. And in fact, we know from other aspects of medicine that people gain great support from talking to their peers, their family, their friends. So if people have had the vaccine, and the worldwide experience is these are very safe vaccines, and the side effects, yes, they're there, but they are quite mild. That needs to be transmitted to everyone you know. It wasn't that bad, and I'm pleased I got it. In terms of screening for the variants, obviously I'll defer to Dr. Evans. We need to build up the capacity within our laboratories to test for these variants. Why is that so important? Well, as Dr. Evans has said, as we learn about these variants, if they are more transmissible, then that may affect our plans around some of these public health measures, which we're not very fond of, these lockdowns. It may influence whether we open up and how we open up. It also may influence some of the vaccines, because if it determines, and we have, as he said, the evidence is not that they're interfering in any way with vaccine efficacy, but if so, that's information we need. So we need that information to plan for Ontarians to make sure that we get through this and see the light at the end of the tunnel. But Dr. Evans is better to talk about the capacity, but we need it in our laboratories. We need to be aware and we need to test.
Thank you, Dr. Wright. Dr. Evans, did you want to build on that, the capacity piece?
Yeah, happy to add on to Dr. Wright's very eloquent comments. So one of the things is that we've had to very quickly try and ramp up our capacity to do whole genome sequencing. The testing that we do to find variants is actually a bit complex. It's time consuming. It requires resources. There was some investment in it at a research level, but that's really been now amplified. And particularly here in the province of Ontario, I know my colleagues who work at the Public Health Laboratory in Ontario, as well as hospital labs, including my own, have now really ramped up our ability to do genomic sequencing to look for and find these variants so we can understand where they are, how they've proliferated. And as Dr. Wright was commenting on, we need to develop our strategies about what does that mean if a particular variant with some problematic expression sort of pops up. So we're getting there. It would have been nice to have been there a little bit earlier. I think everybody knows the original B117 variant that arose in the southeast part of England actually was first detected back in the fall. So we're a bit behind, but I think things are improving very quickly with the help of my colleagues who work in laboratories to try and find the variants.
Thank you for that. Dr. Evans, I'm going to keep going with you. You touched on the answer to the question Kylie Taggart from the Medical Post has here, but there's kind of three in the row here that are related. It's what is the process to test for the most common variants? What proportion of samples positive for SARS and COVID are being tested for the most common variants? So looking at that, and Dr. Razak, you may have something to add to that as well. And then are all lab screening samples labs screening for the most common variants? So maybe Dr. Evans, you can start, and Dr. Razak, if you could add to that, that would be wonderful.
So one of the things that's happening now is we've developed a rapid screening test in order to find viruses that may be suspicious to be a variant, and then we can subject them to whole genome sequencing. So part of that is to look at coning down our ability to focus on the areas on samples that may have the variants. And that may be related to issues around a lab screening test, but it can also be related to epidemiological features. In other words, a virus, an outbreak of COVID-19 in a particular facility, workplace, long-term care home may give you hints that that's a variant, and then we can speed up that sort of testing. Essentially, the sort of whole issue is that the mechanisms to detect variants are still a little bit problematic. We can find them. It's just really efficiently using the resources we have in the lab to be able to find them quickly and to discern where and how they're spreading around the province, for sure.
Dr. Razak, can you add to that from a broader data level?
Yeah, I think Gerald addressed it really well. I'll just add very briefly that in the hospital sector, so I'm a general internist that provides care for hospitalized COVID patients. In the hospital sector, because we're dealing with patients who are now sick enough to require hospitalization, we're shifting to testing all patients who are hospitalized with COVID for the variant, at least at our hospital, and I think that's going to spread across the province.
Great, thank you. We also have a question about the wastewater studies. I'm not sure if someone on the panel has a perspective on that, but otherwise we can get back to you over email, Dr. Evans.
Yeah, so wastewater sampling, as people know, is a nice early warning indicator that has been used in some jurisdictions. The city of Ottawa has done a pretty good job, and they continue to look for it. Exploring variants that may appear in wastewater detection methods would be another way to look for where these variants are popping up at the moment. The one other thing I can add on to what Fahad was just mentioning, sorry, we use our first names because we know each other, we're kind of buddies. The issue there is that we are doing point prevalence studies in the province. In other words, we're taking all samples from, for instance, one day from a number of selected sampling areas across the province, and we're examining all of those with whole genome sequencing to find the variants. So that's another methodology we use to kind of find out where is the extent of variant spread, and looking at a single point in time, which is typically one day.
That's great. I'm going to get to Diana Duong from CMAG News. Thank you for waiting, Diana. I know you have a few questions here. So the first one is about masks. Most Canadians are still wearing homemade store-bought cloth masks. Given the variable efficiencies of cloth masks, are they still appropriate as the number of cases for more transmissible variants continue to spread throughout Canada? Maybe I'll ask Dr. Kwan to answer, as I'm sure you have patients coming to you asking if this mask that they bought at the store is okay.
So that's a great question. The most important factors to consider for masking is the number of layers, so the filtration, and also the fit. So regardless of whether it's a homemade or store-bought, you should always make sure there's at least 3 layers that will adequately have enough filtration. And also it has to be tight to your face so that there are minimal gaps around the nose area and the chin area, so that you're not just breathing and having air coming in through the sides. So those are the main concerns. And also we have to remember that masks are in addition to other measures such as hand washing and distancing. So we have these increased variants, but it's still important to adhere to all these public health measures. With the increased risks with the variants, if available, if there are surgical masks or medical grade masks available to you, then of course you can use them. But unfortunately, it is still a lack of access for some people. So the most important thing is that if you only have access to store-bought or homemade cloth masks, then of course, as long as you're ensuring that the filtration and the fit is good, then you should still have adequate protection.
Thank you so much. Those are such important tips to remember. More mask questions. I'm going to direct this question to Dr. Wright. It's the second part of Diana's questions, and this is about N95 masks. The Government of Canada says surgical masks and N95 masks must be kept for healthcare providers and has not changed its stance on masks for the public. But should doctors be recommending better masks for patients given these new, more transmissible variants?
So I think Jennifer's answered the second part of your question, which is it's not just the mask, it's all the other public health measures. I would only add to Jennifer's, Dr. Kwan's comment, is that also stay at home. If you really don't need to travel, and unfortunately many essential workers don't have that option, but if you don't need to be out and about, particularly larger crowds, Super Bowl Sunday and the like, I'm afraid it's best just not to be out and around. So the N95, which is among the category of masks which are called respirators, are much more effective. As Dr. Kwan said, they both have excellent filtration, and they have to be fitted in a certain way. So they provide a not airtight, but a very impermeable barrier. Right now, we're not out of the woods, to use a phrase. COVID, unfortunately, is still in many of our ICUs and in many of our hospitals. And we recognize that those who are on the front line are exposed to this, unfortunately, and it's not just them, of course, it's their loved ones. So for the time being, I think these high-grade masks, particularly the N95, do belong in the area, but staying in the area for healthcare workers. Surgical masks are more widely available, but I would emphasize that there are a lot of masks out there which look like surgical masks, but they're probably not manufactured to the same quality. So you have to be a little bit suspicious. And to build on Dr. Kwan's comments, the more layers, the better.
Thank you for that, Dr. Wright. Dr. Razak, I'd like to ask you a question about your research, actually. And before I get into that, I'd like to let the reporters know that we'll be doing a final round of questions. So if there's anything else you'd like to know from our panelists, please put it up in the Q&A or email one of our team members at Crestview Strategy or the OMA, and we'll make sure we get to your question before the end of the session today. But the question is, if you could elaborate a little bit on the stats that you shared, showing lower hospitalization rates for heart attacks, et cetera. What does that mean in real terms, in terms of the impact that we're going to see on patient care now and as we move out of the pandemic?
Yeah, that's a great question. So we know that there are conditions that are important to deal with as soon as possible. So brewing infections, worsening of your underlying heart disease, early changes that may be significant for development of cancers, for example. And the worry is that if people are afraid to present to healthcare institutions, whether it's their family doctor or to the hospital, that these diseases could progress, and they may progress both in terms of severity or reach the point where our treatment options become limited. So that's the real worry. And there's evidence in Canada from SARS, so nearly 20 years ago, that even 12 months after the epidemic started, the number of people presenting to healthcare institutions continued to be reduced. And so there's a worry that there's going to be a lingering fear that going to a hospital, going to a family doctor's office would expose you to COVID. And I just want to emphasize that there is very, very little evidence that that is the case. So this has been looked at extensively. Hospitals are safe for you to come to, even if you have a non-COVID illness. And so it's really important that the public understand that we can safely care for your non-COVID illness in hospital, even during this pandemic. The final thing that I would say is that the initial drop in patients coming to hospital that we saw during wave 1 of the pandemic has largely resolved, at least for those acute conditions. And so right now we're dealing with a situation of hospital capacity again being a worry for the system. And so you're seeing a lot of these system integration steps that are taking place. So the transfer of patients between hospitals to try and offload the ones that are most heavily strained by COVID. So for example, hospitals in the Peel region have especially been hard hit. Hospitals in the Scarborough region have been hard hit. So in the first wave, we saw less people coming in. In the second wave, we're seeing capacity demands, but we're still worried about people being afraid to present for non-COVID illness.
Thank you. I think I'm just seeing if we have any further questions from the media here. You know, I'd like to talk about priorities around safety and around what you would like the general public and what you'd like to see happen in our healthcare system. So maybe I'll do a bit of a roundtable and everyone can talk about, you know, what do you think the priorities are in your particular practices? Dr. Kwan, maybe you can start with us and talk about safety in primary care environments.
So just to echo the previous comments as well, so seeking care for your medical conditions, not just for hospitals, but also for primary care, talking to your family physician is very important. So we do also see delayed presentations to primary care for patients who may be afraid of coming to the office. But we do have a lot of safety protocols in place to protect people who come in with a lot of enhanced screening, distancing, masks, so that if someone does need to come in for an exam, they are generally protected, as opposed to even a grocery store. I would say that the hospital or medical practice is probably safer. So it's still very important because, for example, I'll have patients that they had severe crushing chest pain last night, but they were too afraid to call or go to the hospital, but they could have really died overnight from a heart attack. So if you're thinking that you're having a medical emergency, it's still very important to seek medical care.
That brings to life in real terms exactly what Dr. Razak was describing to us. Dr. Evans, could you share with the media your thoughts on what the priorities should be moving forward through the pandemic?
Yeah, I was going to talk a little bit about safety around. I do infection prevention and control here at Kingston Health Sciences Center, and you know, we're very fortunate. We live in a part of the province that's been very successful in controlling community prevalence, which has been an incredibly important part of safety in general to all the sectors out there. But having said that, there's no question that in the acute hospital sector, where you would come for acute care of serious medical conditions, hospitals are very safe. There have been outbreaks reported, but most of those are related to lapses that occur in some IPAC type practices that happen. But transmission between patients and or from staff to patients is actually considerably uncommon. We know a lot about the transmission of this virus now. And, you know, hopefully that recognition that we understand how transmission occurs in the vast majority of circumstances should reassure people that when they're encountering the healthcare system in general, all the measures that we have in place are to ensure very safe patient care, and they should feel secure in making sure, in understanding that their medical condition can be taken care of. I think at this point, people should not be worrying that going to your physician's office or going to an emergency department or being admitted to the hospital poses any substantial risk for COVID-19. I have been quoted as saying one of the safest places to be in the middle of a pandemic is literally inside a hospital. We have very stringent IPAC precautions, which really help not just to prevent transmission of COVID-19, but to prevent the transmission of a whole host of other diseases and infections which can arise in a healthcare setting.
Thank you. I'll go to Dr. Razak and then Dr. Wright, and then back to Dr. Hill to close things off if we don't have any more questions from media, and we are getting close to our 2 o'clock time mark. Dr. Razak, you have What do you think the priorities would be? You have the closest thing we might have to a crystal ball to the future. What do you think?
Yeah, so I think the biggest worry for practitioners in the hospital sector, which has really went right up to the brink during the second wave, when you look at the data that was being presented by the government, by Adelstein Brown, the majority of hospitals in Ontario were just a few beds away from reaching capacity in their ICUs. And as someone who's on the ward side, we were constantly shuffling patients back and forth to try and enhance ward capacity. The new variants could tip us over, so that's the greatest worry that I have. And I think important from a messaging perspective is that the very same things that we've been telling people for the last many months are as effective against the new variant, but they have to be adhered to. So the importance of physical distancing, the importance of using a mask, the importance of limiting interactions except for essential purposes, those steps become even more important now with the possibility of the variant overwhelming our system. So I think many of us have looked in horror at collapses in the New York health system or in Italy. We're not that far away from something like that happening here, and it can be the difference between a few weeks of uncontrolled spread of the new variant. That could be as little as it takes to push us over the brink. And so I think the importance of holding on, even in this time of fatigue, I think everyone is tired, but holding on for the last stretch to get people vaccinated, for the warm weather to arrive, for all those things to happen, for virus transmission to go down.
Thank you so much. Dr. Wright, your thoughts as we hopefully enter our last stretch?
Thanks, Morgan. I think I'll focus on the issue of worry. The initial estimates for vaccine development, at least what I heard initially, and based on our previous history, is it would take years. And instead, we have a modern day miracle of 9 months from the almost the beginning of the pandemic to approvals around the world and in Canada. I know everyone's tired of hearing that there isn't enough vaccine, but that is the reality. So while it's come at a miraculously fast rate, everyone wants it now. I think we're going to have to accept that there's going to be prioritization. Not everyone's going to get it in the time frame that they would like, and we have to step back and recognize those at most risk belong at the front of the line. And that's hard, that's difficult, but that's what we need to do as we head into the final stretch and keep the transmission low. Thanks for looking after us today, Morgan.
My pleasure. Dr. Hill, I'll hand it over to you to share some closing remarks. And I'm just going to put the OMA media address up on the screen as well as a reminder to anyone who still has questions.
That's great. Thank you so much. And thank you to our esteemed panelists for really helping to lead the conversation here and provide us with great science and understandable answers. One of the things that I want to close on is the idea of perfection versus good enough. And it's something we talk about a lot in parenting and in teaching. And I think it has an application here as well. When we see people asking us about N95 masks versus surgical masks versus 3-ply cloth masks, there's an idea that if we do everything perfectly, we individually will be protected. And that's not how this works. You can do everything perfectly and still wind up getting COVID because there are factors beyond your control. So what we have to do as a community is not aim to do everything individually perfectly, which is not just unreasonable, but it's also exhausting, but to try and be good enough as a community. And so that means all of those public guidelines that you've heard 1,000 times and that you're getting tired of hearing and even more tired of doing. And it means the policy procedures that need to be in place to facilitate that. And so you've heard us call for things like sick days so that people have a choice to stay home when they might be at risk of contaminating others. And it means that we need help for our long-term care homes, of course, which have been so pivotal in what's been happening here and what we've seen happen here. But to the general Ontarians and to the general public, the message would be to stay the course. Most of you have been doing the right thing for a year now. We are decades ahead of where we could have been had we not found this vaccine. We are closer to the end line than we would have been had we not had the vaccine. Do not stress over which mask you're wearing so much Do not stress over whether you're 6 feet or 7 feet away from people. Do not stress over whether you get the Moderna or the Pfizer vaccine. Just keep doing the things that you've been doing. And namely, of course, that is wearing your mask, staying away from other people when you can. If you can't, then you go get the help that you need. That's what your doctors are there for. And you can trust your doctors, whether they're in hospitals or in clinics or in offices, to have taken the best precautions they can to keep you safe. To the reporters, I really hope this session was helpful in informing your reporting and helping you to bring the news to the people, so they say. I look forward to watching and reading your coverage. And again, if there's a topic you'd like to hear doctors discuss, or if you need any follow-ups, please reach out at media@oma.org. Thank you again to everyone for your time. Stay safe and stay healthy.